So this lab is going to have two main kind of learning outcomes, I guess. The first part of the lab is going to be the actual practical way we measure somebody's blood pressure. Obviously, you want to be able to measure someone's blood pressure without sticking some probe within their arteries. So we have this way, it's called the Oscultatory Method for the indirect assessment of blood pressure. So we're going to talk about how that works. That's with a blood pressure cuff and the stethoscope. We'll talk about the details of how you do that, why it works on a theoretical level, get a little practice actually kind of reading measurements and seeing how that goes. There'll be like a little quiz to make sure that that makes sense to you all. We'll kind of do that in breakout rooms. And then we'll do the second part where we're actually going to use the ability to measure blood pressure to see how blood pressure is affected by exercise or by pain or by nicotine, smoking. But the first part of the lab is going to be looking at how we actually measure blood pressure. So what I'm going to do is I'm going to talk a little bit about it. I'll show you a little video. Then you'll actually do some stuff on your own, like I said, in breakout rooms to practice a little bit. And then we will regroup, and then we'll go into the second part of the lab. Okay. So first things first. We're talking about, blood pressure in systemic circuit. Most of the time when you say somebody's blood pressure is 120/80, you're talking about in the systemic side of circulation. The blood pressure on the pulmonary side is going to be like, 1/5 of that, right? Because pressure is a lot lower. So when we're talking about somebody's blood pressure, we're just it's implied that we're talking about the systemic arterial pressure. And it's going to be arterial because the pressure in the veins we're going to find is really low. So we're talking about, all right, let's look at the major arteries that are supplying the body, the brachial artery and the carotid artery and all of that kind of stuff. So, and as you get down into the smaller, dinky little arterioles feeding capillary beds, it's also going to be lower pressure as well. So we're talking about major systemic arteries. Other things we need to talk about is flow and sounds. I've used this word once before. If things are flowing smoothly, we call that laminar flow. When there's some kind of obstruction or constriction and the flow starts getting all cattywampus like that, we call that turbulent flow, right? You can just think about a stream that's completely like straight, just kind of like whoosh, versus like some rapids where it's going whoosh, right? The white water, this is like the white water. If you're going down some rapids. And it turns out that the sounds are going to be what's important. This method we're going to be using is called the Oscultatory Method. Auscultate means to listen. So this auscultatory method, we're going to be listening to blood flow using a stethoscope. And smooth laminar flow is silent. When things are flowing without any obstruction and just getting a nice smooth flow, you don't really hear it. It's just like, when things are turbulent, this makes noise. This is noisy. In fact, we're going to have what we call the sounds of Korotkov. Like when blood is just kind of pulsing through an artery that is not constricted, wherever you have smooth laminar flow, it's just like, you don't hear it. Even though, imagine like flow through a pipe. If nothing is weird in there, you put your ear up to the pipe, you don't really hear anything. But if you have turbulent flow, you hear the because there's all this kind of mixing and stuff going on, right? If I like air coming out of my lips, if I like have my lips just kind of open and let the air just go smooth, you don't really hear me breathing. If I like constrict my lips, you hear every one as the air is all right. So when your blood is coming, and it's going, the pressure is going up and down, but as long as it's smooth laminar flow, you don't really hear anything. It's silent. If it's turbulent flow, though, as the blood pushes through, you hear this like sometimes people say it sounds kind of like a tapping sound, like this. So that's going to be important for understanding how this whole system works. Smooth flow is silent. Turbulent flow, particularly if a artery is compressed, you're going to hear it if you put a stethoscope and listen. All right. So now everybody knows the blood pressure cuff. Its official name is the Sphygmomanometer. Is basically, we're going to take our subject here. Here's our subject. We're going to think about the brachial artery coming through. This should look very familiar from our lab last time. Brachial artery comes through, then it splits into the radial and ulnar artery and the little arch and all that. So here's our brachial artery. Brachial artery. If we were actually in lab at this point, I would have you feeling and make sure you know where it is. I mean, hopefully you all did that during the lab on Tuesday, so you have some sense. But it actually is important to know where it is, because you are going to put your listening device on the brachial artery. You've got your little stethoscope. on the brachial artery. So if all else being equal, let's say I haven't done anything yet with a sphygmomanometer or anything. I'm just putting the stethoscope there on my brachial artery, just kind of resting it on top. What am I going to hear?
Nothing.
Nothing. Because the blood is just flowing smoothly like it normally does, and it's silent. So you don't hear anything in this case because the blood flow is smooth and uninterrupted and no turbulence. So the other piece of this process here is going to be the sphygmomanometer, which has two parts. One part is this blood pressure cuff that has this inflatable bladder. So let me infallible bladder, inflatable. And then obviously if it has an inflatable bladder, we need some way to inflate it. And that's going to be this little bulb. There's a little needle valve here. This little valve here lets you either make it so you pump it up or you're bleeding air out of the bladder. So valve, basically clockwise, you can inflate, counterclockwise, deflates. Right, so it's always kind of interesting. Sometimes people are pumping and pumping and pumping and pumping and nothing's happening. It's because they forgot to close this little valve to make sure that the system is allowing the air from the bulb to go into the bladder. After you're done, or during the process, when you want to bleed air out of the bladder, then you have to turn it counterclockwise, and then the air will escape out of the bladder. Then the one last part of this is there is a manometer, a little thing that basically 0, 100, that's actually hundreds usually over here, maybe 140, I don't know, 200, whatever. This is basically the pressure in millimeters of mercury that are inside the cuff here. So this is my system. I have this ability to start using this pump to start pumping up the bladder and putting more and more pressure down, which is going to be compressing the brachial artery. And then I also have the ability to let the air out and let the pressure come back down. And I also have a readout of what exactly is the pressure at any moment. Whack! That's not what I meant to do. What is the actual pressure inside or that the cuff is pushing at any moment? So there's going to be kind of three parts to this. I'm going to take the stethoscope away just to give myself some space here. Let's put the stethoscope off to the side so you can still see it's there. So the stethoscope, you're listening. So step one. Step one is you're going to pump up the bladder until you completely stop all blood flow to the going through the brachial artery. Which means what? What do you have to pump it to? What kind of pressure do you need to get to if you want to have it pushing so hard that it blocks all blood flow? What's the maximum pressure that the blood is pushing with as it's going down, trying to get down to your lower arm? Remember we talked, what are the two different measurements we use when we talk about somebody's blood pressure to characterize their overall blood pressure? Anybody? This is something you probably knew before you came into this class.
Is it 5 liters per minute?
No, that's flow. That's cardiac output. We're talking about blood pressure right now. What are the two numbers we usually use when we are characterizing somebody's blood pressure?
Are you talking about like diastolic and systolic?
Yeah, exactly.
Okay.
Right? Systolic is the pressure, the higher part during systole. Diastolic is the lower part of the pressure, like during diastole when the ventricles are refilling. It's the pressure that's being driven by that elasticity of the large arteries leaving the heart. Right, so that's important. Maybe I have to review that again. Blood pressure. There was systolic over diastolic. If you just look at blood pressure in millimeters of mercury, millimeters of mercury, it's going up and down and up and down. We said typical would be maybe up to 120, down to 80, back up to 120, back down to 80, just going up and down, up and down. The peak is a systolic, the trough is a diastolic. The difference is the pulse pressure. 1/3 of that difference plus diastolic was the mean arterial pressure. So does everybody remembers now diastolic and systolic? That's going to be critical. Otherwise, measuring blood pressure isn't going to make any sense if you don't kind of remember what blood pressure was here. All right. Back to here. What is the pressure of the blood that's trying to come down through past this gauntlet of the cuff here? What's the maximum pressure?
120.
Yeah, in that case, if it's 120 over 80, it would be 120. It's whatever the systolic pressure is. Right? The systolic is the hardest that the blood can push as it's trying to get down the arm. So if I want to completely block off all blood flow down the arm, what pressure do I need to pump this cuff up to?
A little over 120.
Yeah, or let's just say, let's leave it a little more generic right now, somewhere over the systolic. So I need to pump it up to where I'm greater than the systolic blood pressure. And that is going to block all the blood flow down the arm. It's basically putting on a tourniquet. So that's going to be part one. Pump the cuff. It has to be greater than whatever their systolic is. Typically you assume that their blood pressure, if the person's isn't really incredibly hypertensive, if you go pump it up to 160 or so, you're probably gonna be okay. Usually around 160, 140, 160. There's no reason to go way more than you need because it's going to be really uncomfortable. But you do have to get high enough that you are blocking the blood flow. What are you going to hear in the stethoscope at this point after you've pumped the cuff up above their systolic blood pressure?
Is it going to be noisy?
Think about it. If the pressure in the cuff is greater than the pressure of the blood that's trying to get down the arm, what's going to happen? What are we going to see at this point?
There's going to be no sounds because there's no blood flow.
Exactly. Right? It's going to be silent again, but silent for a different reason. It's going to be silent now because there's no blood flow coming down the brachial artery. So after you've pumped up the cuff above systolic, it's going to be silent because there is no blood flow coming down the arm. You have pumped the cuff greater than the highest blood pressure. If you do hear something, that is a signal to you that actually this person's blood pressure is higher than whatever you pumped it to, and you're going to have to go a little more even to actually do this process. So typically 160 is more than enough, although like I said, if you do hear sounds at this point, that means that some blood is actually making it past, so you're actually going to have to go even higher. So once you have that point where you don't hear anything, you've pumped up the cuff to a greater pressure than their systolic, you don't want to linger here. It's very bad bedside manner to just leave somebody with their arm completely like cut off to circulation. It's going to start feeling really uncomfortable. So you immediately twist this little valve. And you start letting, so on this thing, maybe it'll be 160. I have the little thing will be at 160. I am now going to undo my little valve and start letting the air escape from the cuff. And you want to do it fast enough that this thing doesn't take too long, because like I said, otherwise your subject is going to start getting very uncomfortable because they're cutting off all the blood flow to their hand. But you can't do it too fast because you're going to miss when the things happen. So it's usually like maybe like 2 millimeters of mercury per second or something. You start bleeding the air out. So let air out. And this thing is going to start moving down, down, down. You'll see the pressure in the cuff start going down. And you keep listening. This is your ear over here. At some point, you're going to start hearing some tapping sound. And what does that mean when you start hearing some tapping sounds?
Turbulent flow.
That means turbulent flow. That means there is blood here now, but it's turbulent, which means that this cuff is still squishing. So the blood is not flowing freely. So we must be below systolic, because if we were above systolic, still nothing would be getting through. But we need to be above diastolic because the blood isn't completely free. So the blood is still getting through, but it's getting through, but partially compressed. Right, so again, one was inflate cuff greater than the systolic blood pressure. You start deflating. You hear those sounds of cord cough. And remember, in here, we're silent because there's no flow at all. You start deflating. When you hear those sounds of Korokov, then you know you've dropped below the systolic blood pressure. So you have to note this. You have to be watching that little pressure gauge and remember, when did the sound start? It's auditory. You're going to see the little needle like starting to bounce before this happens. It's not about seeing the needle move or bounce. It has to be about the sounds, about hearing. In fact, this is called the Oscultatory Method, for the indirect assessment of blood pressure. Oscultatory method because it's about listening, about the sounds. Indirect assessment because you're not actually sticking a probe into their artery. You're actually doing it in this indirect way. So sounds of Korsakoff start when the pressure in the cuff drops below systolic. Continue deflating till sounds stop. What does that mean as the sounds stop, as you continue deflating the cuff?
That
Blood
you've
is
reached
flowing
laminar
properly.
flow.
That I've reached laminar flow, exactly. So now I have completely unimpeded flow, which means I must be below diastolic. So you have to note this as well. So basically, you're going to pump it up until there's no blood flow and it's silent. You're going to start letting the air out. When the sound starts up, that's how you know that you have now dropped below systolic. So now you know where the systolic pressure is at. That's where the sound started. You keep letting the air out. When the sounds stop, that's now where you have completely free flow. There's no compression at all, so you're below diastolic. And then at this point, just bleed the rest of the air out. Right? There's no reason to keep going slow here because it's just kind of unpleasant for your subject. You got the information you need. So are there any questions about this? Like, part of this lab, you have to be familiar with both just the mechanics of how you do this, as well as the theory of why it works. Why is it quiet when you first pump up the cuff? Which is very different from why it's quiet till the sounds stop here. Yeah. Quiet and quiet, but for very different reasons. And theoretically, why does this work here? All right. Just kind of showing you how this works in a picture before I have you going into these other little things. Blood pressure background videos. I'm not going to show you this whole thing, but I'll show you part of it here.
I'm about to drink some mud, and I think you should too. People often ask us why we are...
Okay. This woman goes
This
into...
video was created by the Ohio...
She goes into more detail about things than you need to know, so don't worry about extra stuff, pulse obliteration and things that she's talking about. Just kind of pay attention to the main points about how you do the blood pressure.
Ohio Academy of Family Hypertension, the 2004 of annual reading of indirect blood stethoscope,
Okay. Here.
less than 140/90.
Okay. So
Taking a manual reading of indirect blood pressure requires a stethoscope and a sphygmomanometer. The stethoscope used should have tubing long enough to allow the clinician to view the manometer while listening to carotid cough.
So here you can kind of see this setup. He's got the stethoscope bell over the brachial artery. That's where you're going to be auscultating, listening. And the cuff is around the upper arm where it has the ability to compress the brachial artery. So this is the setup. In this setup, the pressure gauge is up on the wall. You'll see in a few moments.
Cough sounds. The bell of the stethoscope should be used as it permits better auscultation of carotid cough sounds. A sphygmomanometer consists of a blood pressure cuff containing a distensible bladder, a rubber bulb with an adjustable valve, and a flexible tubing. The tube connects to a manometer which measures the pressure within the cuff. Each part of the sphygmomanometer should be examined on a regular basis to be sure that it is functioning correctly. The needle on an aneroid manometer should rest at 0 before and after each blood pressure measurement. Aneroid manometers should have calibration performed at least every 6 months. Blood pressure readings should be done when the patient is in a resting state. The patient should be seated for 5 minutes prior to checking a blood pressure so that the reading is not artificially elevated due to the exertion of walking to the room. The arm should be bared to the shoulder. A study looking at the effect of taking blood pressure through clothing showed little average change, but found that in patients with hypertension, there can be individual differences of plus or minus 20 millimeters of mercury or more when compared with measurements on bare skin. The patient must be correctly positioned to accurately measure blood pressure. The patient needs to have legs uncrossed and feet resting on a firm surface. The patient's back and legs should be supported by the chair. The manometer should be at eye level of the care team member. The patient's arm should be supported at heart level. A common error in taking blood pressure is the use of an improperly fitted cuff.
So this is, we actually, if we were in lab, we actually have 3 different sized cuffs. So each cuff actually has a little thing that tells you what size arm it's good for. If you use the wrong size cuff, it will give you an inaccurate measurement. They have ones for people with really little arms, ones with people who have particularly thick arms, and then there's kind of the normal size one. But it actually is something you need to pay attention to. If you use the wrong size cuff for the wrong size arm, it won't give you an accurate reading. So I want to get kind of further on because, all right.
Phase 1 carotid cough sound. The cuff is decreased. Blood flow in the brachial artery increases, which creates turbulence. Now ready to measure the patient's blood pressure. Inflate the cuff to 20 to 30 millimeters of mercury above the pulse obliteration pressure. Then deflate the cuff at a rate of approximately 2 millimeters of mercury per second while listening with the stethoscope for carotid cough sounds. As the pressure in the cuff is decreased, blood flow in the brachial artery increases, which creates turbulence and generates carotid cough sounds. Phase 1 carotid cough sounds are clear tapping sounds that coincide with reappearance of a palpable radial or brachial pulse. Systolic blood pressure is determined by the onset of Phase 1 sounds. Phase 2 and 3 sounds are of no clinical significance and are described as softer and longer, then crisper and louder. Phase 4 sounds become muffled and softer as the pressure measurement approaches the diastolic pressure.
Don't worry about all the phase. It's the main clear tapping sounds that you want to care about for our lab. And notice you can see the needle bouncing. The bouncing isn't important. It's what you hear that is important. So I think this video a few moments later will go into an actual example. Here we go.
Millimeters of mercury beyond the 5th carotid cough sound. The blood pressure should be measured at least twice, waiting 1 minute between readings, then recording the average of the 2 measurements. In the following example, please listen for the various phases of the carotid cough sounds while you observe the reading on the manometer.
All right, so you could hear that little thumping. And they wrote down, they noticed, the thumping started when it was 106. And then when it hits 78, the sounds
An
disappear.
auscultatory
And then notice how she then just released the pressure. So there's no reason to keep this thing pushed up against the person's arm.
gap is defined as the
So are there any questions about what you just saw on that video? So hopefully between what I've been saying and just seeing an example here, this kind of makes sense. What I want people to do right now, this will take like 15 minutes. Unfortunately, the thing I used to use, it no longer works because Adobe Flash has been discontinued. So I just changed it a little bit, but this should work fine. These are 3 little videos that are on YouTube. You know, each one just lasts 40 seconds. It shows the manometer, the pressure gauge. You know, they'll pump it up. You know, this is, you know, audio enhanced blood pressure practice number 6. And then you can listen, you know, and you'll hear it going, see it going down, you know, and use your ears, you know. So you can hear, use your ears. And what I am going to have you do is in your groups, just sit with each other and for number 6, number 11, and number 12, kind of agree on what you think the blood pressure is for that person. You can just like kind of write it down on a little piece of paper for now. And then once you all agree on those 3 things, that should again take you like 5 minutes. Then there is just a little quiz where it has some questions where you have to say what you found. And again, it's going to be close. It might not be exact, but it should be close to what you found, as well as a few other questions about this process of detecting blood pressure. So what I would like everybody to do right now, we're going to spend 15 minutes, and I want you to go into this module, all in your group, agree on, you know, about what is the blood pressure for that person in each of those 3 examples, and then do the quiz. And then we will regroup here in 15 minutes and continue with our lab. All right. Okay. Breakout rooms. We're going to go. It's not the same as actually doing it in real life, but at least this is kind of giving you a initial introduction to kind of how the process looks and hears and feels. You know, in reality, like the sounds are kind of quiet. So just, you know, you want to do it so it's pretty quiet outside, and you have to be able to, and even just the moving of the cuff, you know, is that it or no? It's no. You know, part of it is just practice and getting comfortable, recognizing the sounds, and again getting the speed. You have to adjust how fast the needle drops. Depends on how twisted, how tight clockwise or counterclockwise the needle valve is. So that's another just physical thing you'll get comfortable with. It's not too slow. You don't want it to be uncomfortable, but you also want to have it go slow enough that you can see when the sounds start and stop. So are there any questions about just the technique and the kind of theory behind the technique for measuring the blood pressure using this auscultatory method? Okay, so the second part is basically, there's 3 parts. It's 1 part cut into 3 parts. It's going to be blood pressure versus exercise versus pain versus nicotine. In each of these cases, you're not going to have to do anything at home. We're going to describe how the procedure goes, show you a little video of what it looked like when people were doing it, but then you're just going to get data in an Excel spreadsheet that you're going to then have to use and discuss. So there's no actual stuff for you to physically do. It's going to be more about using the given data and discussing the implications of it. In all cases, where basically there's going to be a baseline blood pressure and pulse, or I should say maybe heart rate. So in all three of these, first you just measure, okay, what is their resting blood pressure and resting heart rate? So they're sitting there, they're relaxed. And so this way we have something that we can see a change from. Like I said, resting heart rates, typically around 70, although for younger people, especially if they're in shape, is more around 60, something around that. Blood pressure, even though a lot of times people say 120/80 is normal, that's actually even a little high for somebody who's young and in good shape. It's probably going to be lower than that for a lot of people. Then there's going to be some challenge. It might be exercise, this step test that you'll see in the video where you're stepping up and down on a step for 5 minutes, getting your heart rate going and getting your muscles going. It might be pain, where you put your hand in ice water, where it's not going to actually physically damage you, but it's really uncomfortable and you have to hold it in there for 3 minutes. Nicotine is sucking down a cigarette and seeing what happens as that nicotine gets into your bloodstream and affects your physiology. So then basically you then are going to take 3 readings, 1 minute, 2 minutes, 3 minutes. You're basically going to do blood pressure and heart rate. So like they're going to do the exercise. As soon as they're done with the exercise, wait 1 minute, measure their blood pressure, heart rate. 2 minutes, measure their blood pressure, heart rate. 3 minutes, measure their blood pressure, heart rate. For the pain, it's a little different. They start the pain, 1 minute into the pain, you measure. 2 minutes into the pain, you measure. 3 minutes into the pain, you measure. For the nicotine, basically they smoke the cigarette, 1 minute post-cigarette, 2 minutes post-cigarette, 3 minutes post-cigarette. So that's basically what the lab looks like. And when you're writing this up, it probably makes sense to write each section up as its own little kind of contained thing. Like have there's going to be an introductory part that's more just about blood pressure in general. But then for the exercise, probably have the instructions, the methods for the exercise, have the data for the exercise, have your discussion for the exercise. Then have the methods for the pain, the data for the pain, your discussion for the pain. Then you can have your methods for the nicotine, your data for the nicotine, and the discussion for the nicotine. That'll make it easier to kind of keep it organized, I'd say. So let's take a look at it. We are now going to look at each of these, and this is going to be, again, not as much fun as actually doing it, because you're just going to see somebody else doing it, and then we'll look at the data, and I'll just kind of discuss the data with you a little bit, so you kind of make sure everybody's kind of really noticing the most important points to keep track of. So here we go. All right. this first part, Harvard step test, this is the exercise part. So this is just going to describe the methods so you can actually have some real sense of what's actually happening to get the data that we're going to look at. So here we go. All right, we're going to start with an overview of the exercise part of the blood pressure experiment, where you're going to take an initial baseline blood pressure and heart rate for your subject while they're sitting quietly. Then you'll start a timer, and they're going to do the Harvard step test, going up and down on the step for 5 minutes. As soon as they're done with those 5 minutes, you now start a new timer, and you have them sit down, and after 1 minute post-exercise, you'll take their blood pressure and heart rate. At 2 minutes post-exercise, once again, you'll take their blood pressure and heart rate. And at 3 minutes post-exercise, once again, you'll take their exercise and heart rate. After you've got your data, you can calculate their fitness index and continue on. All right, for the Harvard step test, I'm going to be stepping up and down in a very specific rhythm for 5 minutes. It's 1/2 second per step. So 1 and 2 and I have to keep up that pace for the entire 5 minutes. So we're gonna have, she's gonna start me off here. Tell me when to go.
Ready, set, go.
And down and up and down and up and down and down. I'm just gonna keep going for 5 minutes. My lab partner here is making sure that I'm not starting to slow down. If I'm going slow, she's gonna
Keep
tell
on,
me.
dude. You can do it.
So be careful not to fall off.
4.5 more minutes. Good job. Keep going. Sacrificing your body for physiology.
5 minutes and I'm done. Tell me when I'm done.
And stop.
All right, so now it's done. We start the timer now for as soon as this is done. So let's go in there. Now I'm gonna get ready to get my blood pressure and pulse taken.
Well, it's okay.
So at 1 minute after the exercise is over, my lab mates are going to be taking their first reading of my blood pressure as well as my pulse rate. For the blood pressure, it's the normal Oscultatory Method. For pulse rate, you can just get it off of my radial artery, or carotid works as well. And you can either count for 20 seconds and multiply times 3, or 30 seconds multiplied times 2. Obviously, it's going to take at least 2 people, because one person doing the blood pressure, one person doing the pulse at the same time. In the interest of social distancing right now, we can't quite demonstrate that. At 2 minutes post the exercise, we'll take another blood pressure and another pulse rate reading. At 3 minutes post-exercise, we'll take our final measurement of blood pressure as well as pulse rate. And that will be the data gathering for the Harvard step test part of the experiment. Okay. Right, so obviously if, we were filming this right after it was all shelter in place, so normally there'd be somebody there working on one arm with the blood pressure cuff, another person on the other arm measuring your pulse and stuff. And it's part of the reason we decided, even if we could get people into the room, it didn't make sense to try to do the labs, because you'd have to still be distanced. Even if you were in the room with 6 people with distancing, we wouldn't be able to do the lab because you can't touch each other. So does any questions about the actual procedure? Right, so in general, what you would do is you would just measure the pulse rate and the blood pressure at each of those 3 times. There is this thing called the fitness index, which you can calculate using the pulses at each measurement. Like when we talk about somebody having good cardiovascular fitness, in general, what we mean is to do this kind of, if you're going to increase the work of your cardiovascular system, the more fit you are, the less it's going to have to increase to deal with whatever you're throwing at it, and the faster it's going to return to baseline, right? So someone who's in really good cardiovascular fitness, they're going to be able to do this stuff. Their cardiovascular system isn't going to have to like work as hard to try to keep up, and it's going to come back to normal quicker. So let's look at the data and look at what happened and give you kind of some basic ideas of what to think about in your discussion. So I'm going to like share the screen again. So down here, this link here, combined class data, this has the data for all the different parts. Let us save that. So here's the raw data for the exercise. Just different subjects. Here's their baseline readings for systolic, diastolic pulse rate, 1 minute, 2 minutes, 3 minutes post-exercise. You know, this heart rate graph, this is like at the baseline, this is showing that on average, the heart rate went up, kind of basically doubled, which again makes sense. You're going to have to increase the cardiac output, increase the flow, because you've got that all of that oxygen debt. Remember, even though I'm now sitting down and resting, while I was doing that exercise, I was going into oxygen debt, going into all those anaerobic pathways, and now I need a lot of extra blood flow to recover from that, get that extra 11 liters of oxygen. So to have that extra flow, I need to increase my heart rate is one of the ways to increase cardiac output. And then you can see it's over time, it's coming back to normal. I think after 3 minutes on average, people weren't quite at their resting yet. But like I said, kind of measures of cardiac fitness for an individual would be like somebody who's more fit, it wouldn't have to go up quite as far to start with and would come back faster. If we look at the blood pressure graph, this one is one where you really want to pay attention. Systolic versus diastolic. And if you take a look, you're going to see there's kind of some very different things going on here. Maybe let me view, let's increase that slightly. Maybe 100. What do you notice about the change in systolic versus diastolic in response to the exercise? Do they both change in similar ways?
No, diastolic is relatively unchanged.
Yeah, exactly. So this is important. It's important to see here that the systolic went up appreciably, went up quite a bit. It went from like 120 on average to like 160 on average. And again, that is probably a good thing, right? The pressure is what's driving the flow. And we need more flow. We're going to need more pressure to get the blood going to where it needs to go. Get more blood going, more liters per minute to recover. Diastolic, on the other hand, if you think about diastolic is during that isovolumetric contraction what you have to fight. You have to overcome diastolic before any blood actually even leaves your heart and starts flowing into the body. So it's actually a good thing that this works this way. If diastolic was also going up, that would mean that your heart was pushing harder than normal just to overcome the pressure on the other side of the semilunar valve and achieve ventricular ejection. Does that make sense? So having the diastolic say low means that the heart is still doing achieving ventricular ejection like normal. It's just like overall, we have this higher blood pressure to have higher blood flow, to help with our recovery here. So definitely, like in your discussion, you want to kind of talk about, what's happening to the blood pressure, but not just in general. Talk about differentially what is happening with one versus the other, because that's important as well. Here it says, like, for each part of the lab, normally you have your own subject. So for each part of the lab, just pick one of the random subjects in that spreadsheet. Like for the exercise, pick whoever you want to be your subject. Maybe you want to have subject 14 or subject 6 or whatever, whoever is inspiring you, and pretend that is the data from your subject. And when it asks you to calculate their fitness index, calculate the fitness index for that subject. So you still go through the process as if you had an actual subject, but you're just going to pick one of them. Just that way it gives you a sense to a way to compare your subject to the class averages, right? So you have your person, but then you can see, how does my person relate to the overall trends we see? So any last comments, questions on that one? Oh, Brittany's gone. Next, cold pressure test. So we introduced the idea of this ice water bath, and we did referred pain. Things to remember with the ice water bath is it's not going to actually cause tissue damage as long as you equilibrate between the ice and the water, because they have to be at 0 degrees to both coexist. So you can feel safe that you're not going to actually damage your subject. That being said, it really hurts. It's uncomfortable. It's like, ugh! So it creates a lot of pain. And this is always this kind of interesting before we actually look at the data. What do you think is going to be the response of your blood pressure and heart rate to this like intense pain?
Both increase.
Yeah, so I mean, I have to say, before I ever looked at these experiments, I just kind of, my instinct was like, of course it must go up. That's what you always kind of, think about. And I think one of the things I love about this lab is kind of showing what's reality versus what is your kind of intuition about things. So let's look at this video briefly, and then let's discuss the data that we see, the analysis as well as the data for the cold pressure test. So let me go back into sharing the screen. All right, here's an overview of the cold pressure test part of our blood pressure experiment. You'll start by taking an initial baseline reading of your subject's blood pressure and heart rate. And again, pulse rate and heart rate are the same here. Immerse your subject's hand in ice water and start your timer right away. Make sure that the water and ice are in equilibrium so we know it's 0 degrees C. After they've been immersed for 1 minute, you will take their blood pressure as well as their pulse rate and record that, keeping their hand in the ice water bath. After 2 minutes, you again take their heart rate and their blood pressure. After 3 minutes, again, you take their blood pressure and heart rate. And at this point, they can now take their hand out of the ice water bath. Then you can continue on with your experiment, calculate their index of response and all.
Okay, so the noxious stimulus and blood pressure relation. I'm going to stick my hand in ice water that has been equilibrated, so a little bit of time for the ice and the water to reach 0 degrees Celsius. And once the timer starts, I'm going to immerse my hand, keep it immersed my group mates will be taking my blood pressure and pulse for 1 minute after, 2 minutes after, 3 minutes after, while my hand is immersed in ice water the entire time. When we take the pulse, we want to take it from the carotid artery this time because, one, if I took it from my radial artery in the ice, that's not doable. And if I took it from my hand that has the arm that has the blood pressure machine, the Sphygmomanometer on it, there's no pulse during the time that the cup's inflated. So the carotid artery is the better artery to take each minute.
So now we're gonna start this experiment. So we've got the timer here. And I'm gonna go start as soon as are you ready to put your hand in the ice water?
I think so.
All right, so here we go. Start. She's got her hand in the cold pressure test, ice water, and at 1 minute, we're gonna take the first reading. It's genuinely designed to cause pain, but not tissue damage, but it can be quite uncomfortable. So it's really, she is actually in pain right there. She's all right. So it's almost 3 minutes. At 3 minutes, okay. Now it's time to take the final reading. Our third reading. We'll have someone with her blood pressure and her pulse. And now we're done. You can get out. All right. You can notice there's that like kind of reflow. It's typical for your hand to get kind of bright red afterwards. Thank you for being such a great participant. All right, here's an overview of the cold pressor test part of our blood pressure experiment. All right, so that's what it looks like. I should mention briefly this idea of index of response. Basically, what you do is you're going to look at systolic over diastolic, at their baseline. And then you look at all the readings in the ice water. And you just find, comparing, what was the largest difference that you measured at any point in the experiment between the baseline and the reading while they were in pain, either in systolic or diastolic. So you compare systolic and diastolic in the pain versus baseline, and then you can see what was the widest deviation from resting that you saw during the experiment. So that's that index of response. And so what we're going to do now is look at the data for this one. Again, here is the ice water. There is an ice water blood pressure graph and heart rate graph, but they're not actually that important. They are actually not that interesting in this experiment, because what is really most interesting is looking at the index of response. So I basically set this up so the index, basically I have my little Excel spreadsheet that finds the maximum systolic, maximum diastolic, the change between them, and then I find the maximum of those, and that's the index of response. So if you look, there's a huge range. You have some people that didn't change very much, 10, a bunch of people that are like 10 or 9 or 10. Other people that it's like 40 or 32 or 34 or 38. So some people had really dramatic swings of blood pressure when they were in pain. Just as many people had pretty minimal swings of their blood pressure. So that is what I really want you to pay attention to. Like when you're discussing this, the averages are actually not as important, I think, in this particular experiment as realizing that any individual response is pretty individual. And yes, it tends to change a bit, but for some people it just changes a bit. For some people it changes dramatically. And this is also important when you are just kind of continuing going deeper into this kind of clinical world where you see somebody's response to something, or realizing like different people respond. What's normal can be really different for different people. Just because somebody has a wider swing or a less swing doesn't mean that they're more or less normal. They're both normal. Like what's normal for this index of response is very widely varying. In the lab, I talk a little bit, there's some correlations about index of response and your, possible susceptibility to different kinds of diseases and stuff. But in general, doing this lab for over 20 years, it's just always amazing how some people barely change and some people change dramatically when you put their hand in ice water. And again, at least for me personally, that was very much counterintuitive. I just figured like, duh, of course it's gonna pain. Their pulse rate and heart rate are gonna go through the roof. If you look at the heart, if we look at ice water and heart rate, this person's pulse rate starts at 78. In the ice water, they're down to 64 and 60. This person's baseline actually went up, though. They went up a little bit from 69 to 72. This person that went from, so some people went up. This person went from 66 to 82. This person went from 75 down to 63. Right? The pulse rate, some people it went up, some people it went down, some people it almost didn't change at all. So just kind of making that clear in your discussion as well, that it's not intuitive that of course their pulse is going to go up if they're in pain. So just kind of putting that out there. Any comments, questions about this one? All right, the last part, nicotine. All right, so nicotine. I can talk a little bit about nicotine. Nicotine is a stimulant. Nicotine is actually something that is going to bind and activate the nicotinic cholinergic receptors, which we've talked about. That's how they get their name, is that they bind nicotine. It actually turns on activates a lot of these acetylcholine pathways in the brain are actually dealing with attention. So nicotine can actually help focus attention. And it tends to be a stimulant. Kind of wakes you up, speeds you up. It's a vasoconstrictor. What would be the implications of something being a vasoconstrictor?
Increased blood pressure?
Yeah, increased blood pressure. So one thing I should mention for this lab, we are just looking at what we call like acute intoxication. In the moment, you've just dumped a bunch of nicotine into their bloodstream, and let's see what the immediate effect is on their body. A lot of the reasons why it's a bad idea to smoke consistently is about more long-term things that happen that aren't necessarily directly happening in the moment. It has to do with stimulating these inflammatory responses that are responsible for different aspects of cardiovascular disease. So there's more going on with nicotine than just these acute effects. But in the moment, we're going to be able to see the results of these acute effects as well. So let's watch the video, and then we will have our final little check-in before we're done for the day. Heck. All right, part 3 is going to explore the effects of nicotine on your cardiovascular system. It's structured just like the other 2 experiments, and here I'll tell you all about it. All right, for the last part of our blood pressure lab will be a nicotine challenge. This is for educational use only. I don't recommend this as a habit. It's not that great for you. For this one, again, we'll have taken a baseline reading on the blood pressure and the pulse rate, and then the subject will smoke a cigarette, and basically you get the nicotine into the body, and at that point, as soon as you're done with the smoking, the subject is going to sit down, and we start the timer again, and it's just like the other parts. 1 minute post-challenge. They'll take my blood pressure and my pulse rate, and that will be the first reading. 2 minutes after I'm done with the cigarette, we'll take blood pressure and pulse rate. And finally, at 3 minutes post-smoking, we'll take the blood pressure and the pulse rate, and that will be our data for the nicotine challenge part of the blood pressure lab. So one of the things that's interesting for this particular part of the lab, this is where you have to kind of think about sources of variability. So, one source of variability, obviously with taking blood pressure is, different things other than smoking affect blood pressure. We just saw exercise affects blood pressure, and you have to smoke outside. You couldn't smoke inside the building. So how would we have to be careful of that when we're setting up our procedure, knowing that just to get to the place where they can smoke, they have to walk there?
You have to have them rest for a few minutes before they smoke their cigarette.
So you're going to have to have them rest a little bit before you can take the baseline, because they're probably not going to be at baseline after having walked to wherever they can actually do the experiment. So that's one thing. Another thing that was hilarious, actually, was there was 1 year where we got really anomalous readings for the baselines, really high. Normally you have a lower baseline, and spoiler alert, things go up when you smoke, but just their baseline was really high, and I was like, what the heck's going on? And it turns out, and I talked to the subjects afterwards, and it was right after the College of Marin had started instituting this really strict no smoking on campus rule, and cops would call you out and blah blah blah. And so people were sitting there, even though I'd kind of said, yeah, sure, go ahead, smoke on campus. They were just kind of terrified that somebody was gonna catch them and get them in trouble. So they were their pulse and blood pressure were up high because they were kind of freaking out that the cops were gonna nail them. So I had to realize I had to get people further away onto the street where they know they're not going to be, and so it's interesting though. But just giving you this idea that sources of variability can sneak up on you sometimes, and sometimes if you get weird results, it's worth kind of following through and figure out what happened there. Yeah, and it's also been interesting. It's been a lot harder to do this over the last few years. It used to be really easy to find like 3 or 4 or 5 people to be subjects for this. And over the last few years, we tend to just use data from previous years because I think it's a good thing. Less people are smoking as much. But yeah, it's definitely been interesting watching just overall habits change over the years. But so data. Let's look at the data briefly. Share screen. Nicotine. So here's the nicotine data. This is showing blood pressure and heart rate in response to the nicotine. And here you can see what it makes sense. It's a stimulant. We have an increase in the pulse rate. Kind of goes up, stays pretty elevated even after 3 minutes. Blood pressure is also going up. And here you can also see that, the diastolic is kind of going up as well. And sometimes you get idiosyncratic results as well. Like a lot of this is going to depend on how much the person smokes normally. Like a lot of times people would be subjects that are regular smokers, in which case, having the cigarette was actually more relaxing for them and things didn't change much at all. Other people who like, I just smoke after I'm drinking at a bar, but sure, I'll smoke for the cigarette, for the experiment. And then they have much more dramatic changes because their body is not as habituated to reacting to the drug. But in your write-up, you're just going to discuss the data and what the implications are. So just like the other parts. So where's my little back? So there it is. All right, so for this lab, again, there's kind of more of the overall blood pressure that we've talked about, and you need to make sure you understand that whole process of measuring blood pressure. There were the 3 tests that we did. For each of them, like I said, I'll say again, you probably want to kind of keep them kind of as like kind of more separated, like, methods, data, discussion. Method, data, discussion. Method, data, discussion. Just, it'll make it easier to keep it organized and see what's what, because in this particular lab, there isn't that much crossover between what were the take-home messages. So any last comments or questions about the blood pressure and what's the expectations for this one? All right, so at this point, we're out 2 minutes early.